The views that I express represent my own. They do not represent my institution or any other agency or organization to which I have an affiliation. When people say ethics is gray, I say for me, it is technicolor. When you're in the midst of an ethically challenging situation, it is vivid. A global pandemic is one of the most ethically challenging situations any one of us will ever have to face. I want to highlight certain provisions of the ANA Code of Ethics. Under contemporary standards of care, the blue highlighted provisions have a prominent role in the care of patients. Nursing ethics is largely relationship-centered. In the circumstance of resource scarcity, notice the shift in provisions and prominence from the Code of Ethics for nurses. We move away from a focus on relationship-centered care and adapt the framework for disasters discussed by Dr. Webster. We adopt an outcomes-focused framework with the two primary goals: to achieve strategies to avoid entering crisis standards of care, and, if crisis is reached, save the most number of lives possible. The two constants are the practice with compassion and respect, and that we owe the same duty to ourselves that we do to our patients. In the context of a pandemic, the shift in emphasis still includes self-care. This can be hard to accept, especially if it means compromising a response to a patient, because failing to protect ourselves will compromise the patient in front of us as well as future patients. This now familiar diagram represents what happens in a pandemic. The CDC diagram shows that in a pandemic, priority number one for healthcare organizations, for all of us really, is to reduce the spread of the disease. We will not stop it. We can, however, mitigate the stress on the healthcare system if we can slow it. We cannot achieve this if we do not focus equally on priority number two, namely protecting our healthcare workforce. Historically, it is the lack of trained quality people that becomes the biggest challenge in a pandemic, not equipment. And finally, we must focus on priority number three, and that is, how do we allocate our resources wisely? Perhaps the thing that direct caregivers perceive most intensely is the shift from the individual fidelity to focusing on the broader community, which by necessity shifts us from autonomy toward paternalism, or the best interest of more than the individual patient. Rather than spend time evaluating available evidence, as in an evidence-based practice change approach, we must rely on internal and external experts and implement changes rapidly. Time and efficiency become drivers for change. In contingency, the spaces, staff, and supplies used are not consistent with daily practice, but they support care that is functionally equivalent to usual patient care practices. We add the strategies of allocation and reallocation of ICU treatment when we've reached a crisis level of care. We use atypical spaces, we lack trained staff and resources to provide the care to all the patients who need them. The balance between what we have and what the needs are has shifted, and we have to make difficult choices. We're addressing resource shortages by conserving, substituting, adapting, reusing, and reallocating. We are using the best information available in a rapidly changing environment. The way we do that is we identify indicators, we look for triggers, and then we identify strategies. I want to use mechanical ventilators as a concrete example of what we do when we manage scarce material resources. Keep in mind these changes happen rapidly and will be hard for clinicians to track and have confidence they are in fact doing the right thing. This is in large part because Monday is one day, and Tuesday people may come to work and find that we're using a new strategy. So thinking about our ventilators, normally in contemporary standards of care, we stockpile, we decrease demand. When we arrive in contingency, we substitute. For example, we might use an anesthesia machine. We adapt. Maybe we'll use a transport ventilator, and we reuse. Under normal circumstances, we would not imagine using a ventilator circuit again, either by cleaning it, re-sterilizing it, and giving it to another patient. However, in a crisis situation, this may be considered a suitable standard to follow. Perhaps the most challenging resource to consider is, what do we do with the human resources? Again, changes happen rapidly and will be hard for clinicians to track and feel confident in how they're working. So we always try and prepare and orient. We always try and conserve by minimizing meetings, cohorting patients. We'll substitute ideally with equally skilled staff, and when that's not possible, we may shift and adapt to adjusting work schedules, less trained staff with mentoring. The piece that has been yet to figure out is, how do we reuse staff? Because in fact, once we run out of people, we cannot build or reuse them, which is another reason self-care is essential when it comes to how we avoid crisis standards of care. We have a strong obligation of beneficence, in other words, to do good, to do what we can to avoid this crisis state, and to know that when we're in contingency and all of the strategies we have used are crossing over to causing more harm, in other words, we recognize that the risks of adaptation do not outweigh the benefits. Care will be inconsistent with usual standards of care, and we will do our best to provide sufficiency of care in a setting of catastrophe. And what that means, if we've achieved a crisis level, is that we may have to allocate and not provide resources that in a different circumstance someone might be able to receive. The standard of care that is applied in the setting of a large-scale emergency is a sliding scale of care appropriate to the resource demands of the event. The standard of care shifts when there's a large-scale emergency. Decisions about resource allocation must be based on criteria that ensure that every patient has equitable access to any care from which they might benefit. Ethical criteria are based on biological factors related only to the likelihood and magnitude of benefit from medical resources. Factors that have no bearing on this include, but are not limited to, race, age, disability, gender, sexual orientation, socioeconomic status, perceived social worth, immigration status. These are just to name a few. These are things that we consider morally irrelevant when it comes to deciding who will receive the limited resource. So many parts of the country are in contingency. Some hospitals, some states, some cities may be closer to crisis than others. Cities, counties, and states are collaborating as never before. Ethicists, critical care specialists, hospitalists, general care folks are collaborating and trying to achieve a unified standard of care. If we must move to crisis, our goal is to do that together. This means, for example, if a patient arrives at an institution that lacks resources, the patient may be transferred to one that has the resource without regard to insurance payments or whether or not a patient is in network. Or the resources may be redistributed to the facility in need until we are all at or near capacity, regardless of who owns the particular resource. If we reach crisis, a designated leader at an incident command will announce the initiation of crisis standards of care.